I'm a senior surgeon. I've had a long career in transplantation surgery, primarily the abdominal organs. I started the liver transplant program at McGill in 1990. I also do kidney transplants, and I assist my colleagues in pancreatic transplants. Although I don't do this primarily, that's not my focus. My focus in liver transplantation has been to target patients with hepatitis B. That was early in my career, and we designed the hepatitis B specific protocol that prevented recurrence after liver transplantation. And it was the most successful protocol. Now that's morphed into basically therapy and vaccination for these patients. And so the indications for hepatitis B have slowly come down. And so it rarely is an indication for liver transplantation anymore. We then focused in mid-career on transplantation, liver transplantation for the indication of hepatocellular carcinoma, which I am actively doing both clinical and basic science research in. Also, I focused on increasing organ donation and sources of organs, both for liver and kidney transplants. In the kidney area, we are one of the most aggressive transplant programs, utilizing older kidneys in a very systematic way to transplant patients. We've demonstrated that these kidneys can be used safely with very good results. We then shifted our focus in the early 2010, 2015 era and focused on obesity and type 2 diabetes, which is a common cause of organ failure and end-stage kidney disease. And patients go on dialysis and require a transplant. Unfortunately, many of these patients have severe obesity and are denied kidney transplantation quite often. So we then asked our colleagues with bariatric surgery or weight loss surgery program at McGill, and along with the Maisonneuve Hospital, we initiated a systematic assessment and the help of bariatric surgery to induce weight loss in these patients so they can become eligible for kidney transplant. And we're now reviewing our results. We have 10-year outcomes that show clearly these patients do much better than if you don't undergo bariatric surgery or weight loss surgery. And we use something called sleeve gastrectomy. So that's an ongoing project, clinical activity that needs periodic reassessment of outcomes. Finally, in the area of more basic science, translational science, we have looked seriously at what causes kidney failure, especially kidney rejection, which is termed chronic antibody-mediated rejection. We published on the role of interleukin 17 and Th17 lymphocytes. We identified these as being central to sensitization and antibody-mediated rejection. And so we designed a program to target the source of these cells, which is the transcription factor called retinoic acid related orphan receptor gamma. And I had the fortune of taking on pharmacology a pharmacologist who designed new drugs, and we designed our own retinoic acid receptor gamma inverse agonists that avoided some of the side effects that the earlier ROR gamma inverse agonists had issues with. And so this program now is achieving quite a great preclinical success. But we also found that this target is very important in cancer as well. And so we are designing many critical studies, preclinical studies. And so we target both the anti-rejection pathways, but also the cancer pathways. And it seems like this is the answer for reshaping the tumor microenvironment, especially and also something called emergency granulopoiesis, which is the root cause of most resistance, cancer resistance to both immunotherapy and chemotherapy. And so we have an opportunity to launch this in clinical trials. I hope this will happen in the next 2 years. And we are pursuing collaboration with some of the pharmaceutical drug companies, as well as other potential clinical trial resources such as CHR and both the Canadian and Quebec governments.